कैसे मैं तो कुछ देख ही नहीं पा रहा, मैं क्या देखूंगा यार, चल नहीं दे रहा मैं। आ गया। चल मैं ले रहा हूँ, तो देख नहीं रहा दूसरा है कर लिया बैठ जाने में, तब भी नहीं आया स्टार्ट में। मेरे यहाँ पर तो लगी फील्ड आ रही है, आपकी फोटो भी आ रही है, आपने फोन मिला है तो मेरे डिवाइस में तो दिख नहीं रहा, क्या करूँ?
एक बार फिर बैक जाके ज्वाइन करूँगा आज।
कैसे बैक जाके यार? व्हाट्सएप से ना? अब आया ठीक है। Yes, so very good evening once again, and we are here to discuss the questions of respiratory system today. So I am Dr. Kamal. So first question, let's begin with, this is a very important concept of surface tension, right? Surface tension. So in an experimental model, two spheres with elastic properties similar to alveoli are connected as shown below, with a clamp positioned between them. So remember, this is a representation of the clamp, right? Clamp, we all understand, something like a connection between two spheres. So what we do is, the surface tension between the two elastic spheres is the same within the two elastic spheres, and neither is lined with surfactant. So there is no surfactant here. So which of the following options best describes what will happen when the clamp is opened? Remember, this question is based on Laplace law, right? Or the Laplace law as we popularly call. And this we also know is written as P is equal to 2T upon R. Remember, this smaller sphere has a radius R1. This larger one has a radius R2, right? That means if I ask you a simple question, which sphere will require a larger distending pressure, P1 or P2? So remember, P2 will be less, but P1 will be more. Why? Because according to this one, if radius is less, then the distending pressure required is more. Normally the clamp is preventing the movement of the air between the two spheres. But as soon as I open the clamp, the smaller sphere will, mind you now, collapse. It will become smaller in size, and the larger sphere will become further large in size. Why? Because remember, this smaller sphere requires larger distending pressure, so I am not able to maintain the distending pressure. So will the spheres become equal in size? No, the smaller sphere will decrease in size, not increase. The larger sphere will decrease in size? No, larger sphere will increase in size. So the correct answer is not ABC, but smaller sphere will collapse, right? Now let's move to question number 2. So regional variations in ventilation, perfusion are measured. Regional variations in ventilation and perfusion are measured in healthy individuals when they stand in upright posture, right? So which of the following correctly describes, as we move from the base to the apex, which of the curves is most likely to be observed? So very important question. Again, the second one, this here I want you to know the relationship between the ventilation, perfusion and the blood flow. So remember, there is a very easy mnemonic here, which is bad. Bad means as I go from base to apex, everything decreases except VQ ratio. Everything decreases except VQ ratio. So VQ ratio in the standing posture is a very, very important topic. You must study it from the videos, and I'm telling you one very easy mnemonic which I've also told you in videos: base to apex. Now I'm going from base to apex, everything decreases, but only VQ ratio will increase. Let's look at the first picture, second, third and fourth one by one. Remember, the C and D are wrong because the blood flow is stagnant, constant. That is wrong, although VQ ratio is increasing. In the picture B, the VQ ratio is decreasing, so this is also wrong as I am going from base to apex. So only correct answer is option number A, right? So just remember, everything decreases means my ventilation my blood flow. My blood flow, you also know, is known as perfusion, and everything will also include my compliance and also my intrapleural pressure. Intrapleural pressure, remember the alveoli which are at the apex are overstretched, so their intrapleural pressure is going to be more negative, right? So everything decreases, right? Intrapleural pressure, everything decreases except only one thing, which is VQ ratio. This is a very important, question for the exam which will come in your first year, right? Describe the VQ gradient in the standing posture in the lung, right? So when the person is in the standing posture, how does VQ ratio vary? Moving on to question number 3. So calculate the FEV1 from the below spirometry reading. Again, an important one. FEV1, as we know, is the forced expiratory volume at the end of 1 second of forced expiration. So we call the patient, we ask him to take few normal breaths like this, tidal volume. Then I ask him to take a forceful inspiration, and then I ask him to do a forceful expiration. As he is exhaling the air, just look at this. Now we are timing it in 1 second intervals, right? So let's go back. So what we are doing is, I want you to calculate FEV1 upon FVC. How will you do that? Just see this. In the first second or at the end of 1 second, he has exhaled around 4 liters of air. But total volume is around 5. That means the ratio is none other than FEV1 upon FVC. FEV1 upon FVC. When you look at this, this would give you the answer 4 upon 5, or approximately we can say nearly 80%, which is the right answer. So best answer is 70 to 79, right? So remember FEV1 upon FVC, read up from the video that how does it get affected in obstructive versus restrictive lung disorders, right? In our recorded lectures which we have given you already in the first year tuition course. Moving to question 4 and 5, the same figure I will use for both. Again, a must know topic from the first year exam angle. Oxygen hemoglobin dissociation curve will 100% come in your exam, right? So diagram given below shows OHDC, oxygen hemoglobin dissociation curve, and what is the P50 of the oxyhemoglobin curve marked A in the above diagram. P50, remember, is the partial pressure of oxygen at which the oxygen hemoglobin saturation is 50%, right? At which 50% of hemoglobin is saturated with oxygen. I want to find for the curve A. How will I do that? Total oxygen is given as 20, right? 20. Half of 20 would be, this is 10. So I pick up a value 10. Now what do? I simply draw a line like this. And what I will do next is, once I have drawn the line to the curve A, I will strike a line to the curve A, and then I will again join the line vertically downwards to my pressure. This is around 30. So interesting question and must know. The P50 is partial pressure of oxygen at which hemoglobin is 50% saturated with oxygen. Right, at which the hemoglobin is 50% saturated with oxygen. Yes, Abhinaman, very good evening. I just saw your message. Yes, very good evening. So then moving to question number 5. Now in the same figure I have asked you which of the following can cause the shift of curve from A to B. So when I look here, just have a look now. Previous image, which of the following can shift the curve from A to B? Remember, A to B is a shift of which shift? Is it left or right? Naturally it is left shift. So again, very, very important, which factors can cause left shift? Remember, there are so many factors such as decrease in PCO2, decrease in hydrogen ion, increase in pH, decrease in temperature, decrease in 2,3-DPG, and remember some important ones which you must know, such as fetal hemoglobin, because remember gamma chains have poor affinity for 2,3-DPG. Then we have bank blood, the blood which is stored in the blood banks. Why? Because it is stored at a lower temperature. Then we have myoglobin, whose curve is extremely left shifted. And finally we have carbon monoxide poisoning, which I will discuss in the another question which I have given you, CO poisoning, right? Carbon monoxide poisoning. So now let's look at the choices for the question. Increased temperature, no, that would cause the right shift. Exercise causes right shift again, right? This is again right. High altitude also causes right shift. The only correct answer is hyperventilation, because hyperventilation will cause CO2 washout. CO2 washout means that the PCO2 will decrease, causing the shift of curve to left side, right? Now let's move to question number 6. So a 55-year-old man with a 20-pack-year smoking history is called for pulmonary function testing. On physical examination, he appears barrel-chested and mildly overweight but breathes normally. Which of the following tests will most accurately, remember the word is most accurately, measure his total lung capacity? Remember, in normal spirometry, you know that we cannot measure TLC because it is VC plus RV. We cannot measure FRC because it is ERV plus RV. And naturally, we cannot measure RV. So these are the volumes and capacities which I cannot measure with spirometry. If I want to measure your total lung capacity, how will I go about it? Remember, I need most accurate method. So what we do here is basically for estimation of total lung capacity, vital capacity you will be doing the practical in your respective colleges. That can be measured by regular spirometry. That means I cannot measure residual volume. So what we do is we measure the FRC. Remember, these three are all methods of measurement of FRC. But the answer is only whole body plethysmography because this is the most accurate one. So answer is this because this is the most accurate. So what we do is we measure the FRC via whole body plethysmography. Then what I will do, once I know your FRC, I will simply use this formula. I will subtract the ERV and I will get the value of residual volume. Once I have got the value of residual volume, I will simply add to the ERV, vital capacity, and I will immediately find out total lung capacity, right? So basically we are finding it indirectly. Why whole body plethysmography is most accurate? Because we say it can even measure the air trapped in bullas. What are bullas? So plethysmography is most accurate because it can even measure any air trapped in the emphysematous bullas. Bullas are the trapped air spaces. It can even measure any air trapped in the emphysematous bullas. It can even measure any air trapped in emphysematous bullas. Bullas are the trapped air spaces. So because it can measure any air trapped in emphysematous bullas, it is considered as the most accurate method, right? Although even CR/DR methods for estimation of FRC, right? Moving to next question now, 7th one. This I will discuss now. CO poisoning, carbon monoxide. 77-year-old male is brought to by paramedics, or the paramedical staff as we call them, after being found unconscious on 2nd floor of a burning building. Now he has no evidence of any burns, but dark soot is caked around much of his face. So this face part is turned black in color. It's dark, right? The color of smoke. Suspecting inhalational injury, you expect this man's oxygen hemoglobin curve will be. So interesting question. What happens here is, just have a look. So what happens here is, if this is my normal oxygen hemoglobin dissociation curve, right? if this is my normal oxygen hemoglobin dissociation curve, let's say I call this as oxygen hemoglobin saturation in percentage, and I call this as your arterial O2 in millimeters of mercury, right? Understand that we don't need any values here. The normal curve is sigmoid in shape. With carbon monoxide poisoning, two things happen. Let's understand that. So with carbon monoxide poisoning, it does two things. First of all, remember carbon monoxide binds with 210 times, some books say 250 also, with 210 times more affinity to the heme than oxygen, right? So what does it mean? Let's understand. Suppose you know that we have this is my first heme to, let's say, which oxygen binds. Second one, again oxygen binds. But now third one oxygen binds, but the fourth one carbon monoxide binds, right? So the thing of interest to us is, let's say this person has a hemoglobin of 16 gram%. This person, I'm assuming, has a hemoglobin of 16 gram%. But if one site is occupied by carbon monoxide, right? Think about it. Then this person now has only 3 places where oxygen is bound. That means his saturation, oxyhemoglobin saturation, is only 75%. I hope you got it. Why? Because out of 4, 3 sites are only occupied by oxygen, 1 has been taken by CO. So first thing to understand here is that the carbon monoxide poisoning decreases the oxygen hemoglobin saturation, right? But the other more interesting thing is carbon monoxide, and appreciate that it also inhibits glycolysis. If it inhibits glycolysis, your 2,3-DPG will decrease. That means the carbon monoxide poisoning not only decreases the oxyhemoglobin saturation, but also causes which side shift? Left shift. And the problem with this is that understand that these 3 oxygen which are bound to the heme, even they are now left shifted. That means, are the tissues going to get oxygen? No. Tissues are not getting this oxygen adequately because the curve has been shifted to left, right? Let's draw this and see how does the curve appear. So when I draw this, the curve is pretty unusual. The curve is like this. Just see this now. So the curve is like this. Not only is it left shifted, but even the saturation has reduced. This is the curve for carbon monoxide poisoning, right? So double problem. Not only that the hemoglobin, this is not like that the hemoglobin is less. 16 grams is a very decent value, right? It's a very good value. But the problem is this person has only saturation of 75%. So this guy is now behaving like a person who has a hemoglobin of how much? 12 gram%. He starts behaving like a 12 gram% because 75% of 16 is 12. But still, what is going to happen? These 3 oxygen are not getting unloaded to the tissues. Why? Because of decreased 2,3-DPG. Why decreased 2,3-DPG? Inhibits glycolysis. Now let's look at the options. Unchanged, no, that is wrong. Shifted right, no. Shifted left, yes, due to carbon monoxide binding, right? Let's move to question number 8. Another very interesting one. A research scientist attempts to understand the influence of carbon dioxide content in the blood on its oxygen binding. What it does is he adds carbon dioxide to rabbit's blood and measures the uptake of oxygen in the blood versus oxygen in the peripheral tissue. He notes that as soon as he adds carbon dioxide with a pressure of 80, the oxygen pressure in the peripheral tissue rose from 23 to 35. So understand this, what we are saying is with increase in partial pressure of carbon dioxide, there is now more oxygen is released to the tissues. So can you think about now, this is which effect out of the 4 options? With increase in PCO2, more oxygen is released to the tissues. This is which side shift? This is right shift of oxygen hemoglobin dissociation curve. Yes, which is this effect known as Bohr's effect. Bohr's, right? Chloride shift in Hamburger I will discuss later. I have given you one more question. Haldane effect, remember, is deoxyhemoglobin binds more carbon dioxide than oxyhemoglobin, right? That is just the opposite of Bohr that we have discussed in transport of carbon dioxide. It's a must know topic, transport of oxygen and transport of carbon dioxide for your exam. The lung volume at the end of maximum inspiration. This is extremely easy. What is the lung volume at the end of maximum inspiration? TLC, total lung capacity. What is inspiratory capacity? It is IRV plus TV, right? Maximum volume of air which can be inspired. Forced vital capacity, FVC, it is IRV plus TV plus ERV. Volume of the air which can be forcefully expired after taking a maximal or forceful inspiration. FRC, ERV plus RV. Volume of the air present in the lungs at the end of normal expiration, right? And TLC is vital capacity plus RV, maximum volume of air in the lungs at the end of maximum inspiration, right? Or volume of air in the lungs at the end of maximum inspiration. Now this 2 or 3 questions I have given you purposefully, from chemical control of respiration, as it is asked very commonly in the exam. So lactic acid given intravenously increases the rate and depth of ventilation due to its action on. Remember, lactic acid is an acid. Acid means H+, right? So please understand, H+ will not do anything to medullary chemoreceptors or central, which is the same. Why? Because hydrogen ion cannot cross the blood-brain barrier. What is BBB? Blood-brain barrier. Hydrogen ion cannot cross the blood-brain barrier, right? It cannot cross. Can the hydrogen ion do something to pulmonary chemoreceptors? Remember, chemoreceptors are either present in the peripheral, in the vessels, carotid and aortic bodies, and not the pulmonary chemoreceptors. So the answer is actually carotid body, which is famously called as your peripheral chemoreceptors, right? So read up both the types of chemoreceptors from the videos. Peripheral chemoreceptors, remember always, primary stimulus for carotid and aortic body is always hypoxia, but there are other stimuli which can stimulate peripheral chemoreceptors, such as increased hydrogen ion, increase in PCO2. The answer to this question, increase in lactates and potassium ion and cyanides, right? They can directly stimulate the cyanides can directly stimulate the peripheral chemoreceptors, right? It can directly stimulate the peripheral chemoreceptors. Question number 11, which of the following is not true about the pre-Bolzinger complex? So very important topic again from the neural control of respiration. I've given you 2 questions. Pre-Bolzinger complex, remember, is located in the medulla. That is absolutely correct, right? It is, remember, this is true. It is the pacemaker of respiration. Must know question from the exam. It initiates the respiratory rhythm. Remember, opioids do not stimulate, rather opioids depress. That is why one of the side effects of opioids, when we give them for pain relief, is the depression of respiration. So they do not stimulate. This is actually false, and my answer. This negative effect of opioids has been taken care because now we have found that there are 5-HT4 receptors which are present in the pre-Bolzinger complex, and there are drugs known as 5-HT4 agonist. Agonist means which are like. These agonist drugs, the 5-HT4, they do not depress the pre-Bolzinger complex, because remember, opioids act through their receptors known as mu receptors. opioids act through their receptors known as mu receptors. So 5-HT4 agonist does not do anything to the action of opioids on the mu receptors, and they do not depress the pre-Boltzinger complex, right? But they can be given for inhibition of pain relief, right? So it was a good question, and these all options are given in Genong. That is why it is a very important question. Question number 12. Which of the following are present in type 1 glomus cells? Another must know topic. Read up the molecular mechanism from the videos. Very, very important. Listen to them once. Type 1 glomus cell are your cells present in the carotid body. They are the cells present in carotid body. They contain the channels known as oxygen sensitive potassium channels. Just see this. I am explaining you once again, revising with you in short. Normally what happens is the potassium ion is going out like this from the receptors, which are through the potassium ion is going out through this with the help of these channels, which are known as oxygen sensitive potassium channels. Oxygen sensitive, that means this movement of the potassium outside requires high partial pressure of oxygen. Interestingly, if I ask you now that the partial pressure of oxygen decreases, that means the person is having hypoxia. So naturally the channels will now close. As the channels close, think about it, what will happen? Can the potassium go out? No. Potassium is what type of charge? Positive charge. So this will lead to depolarization of type 1 glomus cells. So as the channels close, this causes depolarization, right? That is the mechanism, and depolarization will then release the neurotransmitter dopamine, right, via the influx of calcium ions. So this is how the calcium channels will open, just like we have studied in the neuromuscular junction. And remember, inside this we have the dopamine vesicles, and these dopamine vesicles will come out. So this dopamine will be released outside, right? So very important mechanism, must know, right? The dopamine will then come out. Now let's go to question number 13. So spontaneous respiration ceases after. Another interesting question from the transactions. Must to see from the video and know about it. It's considered as an important topic. So normally, what we say is, if I commonly make a figure like this, so this is my cortex, this is my pons, this is my medulla, and this is my representation of spinal cord, right? This is the representation of spinal cord. So remember, this is the cortex. This is the cortex which has mainly the voluntary control on your respiration. Voluntary control, right? Then this is the pons where we have two centers, apneustic and pneumotaxic, right? So please see the entire Then we have the medulla. This is the medulla. In the medulla we have the pacemaker, we have the DRG, we have ventral respiratory group, and your pre-Boltzinger complex, right? And naturally, lastly, I have drawn none other than your spinal cord, right? Now please understand, what we have done here is, I am asking you, when will the respiration cease? Respiration will only cease when you do a lesion like this at the caudal end of medulla, because if you do the lesion at the caudal end of medulla, then what will happen is that there would not be, remember, DRG which is present here, right? Let's represent DRG. DRG, which is present here, dorsal respiratory group, these sends these neurons which stimulate your phrenic nerve nucleus, and it causes the descent of diaphragm. It causes the descent of diaphragm. That means it is responsible for, this will cause the descent of diaphragm and normal inspiration, and we all know normal expiration is passive. So if I do a lesion over here, these neurons are damaged, person will not be able to breathe and his respiration will immediately cease. So transaction of brainstem above the pons, no, above the pons means here over here, voluntary control will be lost. Right, voluntary control will be lost. But if I do a lesion at the caudal end of medulla, as I told you, DRG cannot act. This is the answer. You will have cessation of respiration, the animal will die. Bilateral vagotomy, it will increase the depth of inspiration. Again explained properly in the videos. Please have a look once. If you can recap for me, I'm just drawing one more figure for us. Just see this. So bilateral vagotomy, right? Let's try to recap. An interesting thing, just focus on pneumotaxic and apneustic. Just focus here. The pneumotaxic center, normally pneumotaxic, it inhibits your depth of inspiration. The apneustic center, on the other hand, strongly stimulates the depth of inspiration. And the third, the inhibition is coming from the vagal fibers from the pulmonary stretch receptors in the lungs. These are your vagal fibers from the pulmonary stretch receptors. Remember, they inhibit the depth of inspiration only when the tidal volume becomes approximately 2 to 3 times normal. 2 to 3 times normal. Now naturally, if you cut the vagal fibers, then what will happen to the depth of inspiration? It will increase. Last option, vagotomy combined with transaction at the superior border of pons. So now we are doing lesion like this with vagotomy. So voluntary control will be lost and depth of inspiration will increase, right? So read up the transactions and see the video, and I think we have done sufficient discussion over here, right? Moving back to question number 14. Just a easy one-liner, but has been asked in a lot of university exams. Total work done during quiet breathing. Remember, total work done during is 0.3 to 0.8 kilogram meter per minute. It is done against two forces, elastic and the viscous forces, right? Remember, maximum work is done against surface tension forces. Surface tension forces. Maximum work is done against surface tension forces. Surface tension elastic forces, which is around 43%, which is around 43%, right? Moving on to question number 15. A patient with respiratory volume of 500 ml, intrapleural pressure is measured before inspiration and after inspiration at the end. The pulmonary compliance you have to calculate. Remember, a very, very expected question, because compliance is nothing but delta V upon delta P. Change in lung volume per unit change in pressure or transpulmonary pressure. This is normally my transpulmonary pressure, right, or delta P. Let's look at the value. Now you are given the delta V as 500 ml. The pressure before the inspiration was -4, at the end was -8. If you do this -4 minus -8, you will get the answer as 500 upon +4. You calculate for me, you will easily get 125 ml per centimeter water, right? Just remember, compliance means distensibility or stretchability of the lung. Compliance is distensibility or stretchability of the lungs. Then moving to question number 16, again interesting one. The given graph likely depicts which disease, right? So I want you that what is this? This is my question here, that what is this? Basically, if you look carefully, you will realize that over here we have given volume versus pressure. That means this normal curve is depicting the normal compliance. So any condition which decreases the lung compliance will be my answer. Bronchial asthma and emphysema, interstitial lung disease, normal study. This is not normal study naturally. Emphysema increases the lung compliance, right? Asthma also can increase, but the best answer is interstitial lung disease, where the elastic tissue of the lung becomes thick and is replaced by fibrous tissue. Because there is increased amount of fibrous tissue. Remember, fibrous tissue does not, stretch. That means compliance has reduced, right? So this is interstitial lung disease. Another causes of decreased compliance could be something like pulmonary fibrosis or pulmonary edema, when the fluid has accumulated in the lung, right? Maybe something like this. Just see this. This is the alveolus representation. This is the representation of the pulmonary capillary. In between the two, I have lots and lots of water, fluid. What will happen? Naturally, what will happen if there is fluid accumulation, pulmonary edema, the lung will not be able to stretch, right? Let's move to question number 17 now. 35-year-old man has a vital capacity of 5 liter. Another very interesting calculation based question. Tidal volume 0.5, inspiratory capacity of 3.5 and FRC of 2.5. What is his expiratory reserve volume? Remember, FRC is given to you, which is ERV plus RV. This is given as 2.5 liter, right? So let's look at the options again. What is inspiratory capacity? And remember, vital capacity is TV plus IRV plus ERV, right? I want to find out ERV. So do I need FRC? Yes, maybe not. Just have a look here. TV plus IRV is nothing but, this is known as inspiratory capacity. Now please tell me the answer. Easily you can solve this for me. Vital capacity is given as 5 liters. Inspiratory capacity is given as 3.5 liter. ERV I want to know. My answer is none other than 1.5 liter, right? Moving to question number 18. So we have in the figure shown below, a 22-year-old woman inhales as much air as possible and exhales as much as she can, producing this spirogram. A residual volume of 1 liter is determined using the helium dilution technique. What is her FRC in liters? Please understand, this is the residual volume, right? This we have given you is the RV. But I want you to calculate FRC. You will just have a good look at the picture and you will tell me the answer immediately. It should be from here to here. This is your FRC. But what is this? If I ask you only this is ERV. So what is the total answer? If you look from here to here, answer should be 1 is RV, 2 is ERV, and 1 plus 2, 3 liters, right? The answer is 3. Moving on to question number 19. A preterm infant has a surfactant deficiency. Remember, surfactant surface tension is a must know. You have to be thorough with that concept, right? Has a surfactant deficiency, IRDS we call it, infant respiratory distress syndrome. Without surfactant, you know, there is alveoli will collapse at the end of each expiration, which in turn leads to pulmonary failure, difficulty in breathing. Which set of changes is present in the preterm infant compared with a normal infant? Excellent question, because now I'm asking you, if I don't have surfactant or deficiency of surfactant, what will happen to my surface tension and pulmonary compliance? So let's see this. Interestingly, remember that surface tension, if you could recall basic physics, is a collapsing force. Surface tension is collapsing force, right? It is trying to collapse my alveoli. But we also know that lung compliance is a distensible force. That means if I ask you a simple thing, what should be the relationship between lung compliance and surface tension? So you will tell me compliance is distensibility. And I will agree with you that if more is the surface tension, compliance will be less. That means inverse relationship. But you also know that more is the surfactant, less will be the surface tension, because surfactant reduces the surface tension. Now please have a look at this. In IRDS, infant respiratory distress syndrome, in IRDS, infant respiratory distress syndrome, think about it. Preterm baby, infant respiratory distress syndrome, what will happen to surfactant? Surfactant is less. So what will happen to the surface tension? Increases. And surface tension will increase. Surfactant and lung compliance are directly proportional. So lung compliance will decrease. So what is the best answer? Surface tension increases but compliance decreases. Excellent question and very important to understand the concept, right? Now moving on to question number 20. A group of students decide to go hiking, you know, while visiting Leh. So they are on trekking, hiking. After 3 hours, one of them becomes disoriented. Ataxic, that means he has some problem in his posture. He ataxic, right? He has difficulty in breathing, starts vomiting. So he has ataxic, lack of motor coordination. Diagnostic workup at a nearby hospital shows a decrease in which of the following? So at high altitude, what happens is, let's quickly revise the basics. At high altitude, there is decreased arterial O2, right? Why? Because of, what is the reason? Yes, what is the reason? There is decrease in atmospheric pressure. Because atmospheric pressure is less, there would be less of the oxygen. Less of oxygen stimulates your rate and depth of ventilation. So you will try to, you know, increase your rate and depth of ventilation. As you increase this will cause your carbon dioxide wash out and your immediately arterial CO2 will decrease. So let's have a look. Shows a decrease. As the arterial CO2 decreases, you will have something known as less H plus. That means you will have respiratory alkalosis, right? So less H plus. So pH will increase, right? Please understand that hypoxia only in the lungs causes pulmonary vasoconstriction. Hypoxia only in the lungs causes vasoconstriction. The molecular mechanism is same as we have studied earlier. Oxygen sensitive potassium channels close, resulting in depolarization, and thereby the oxygen sensitive potassium channels close, potassium cannot go out. What will happen? Depolarization, resulting in vasoconstriction. Vasoconstriction means resistance will also increase. And remember, at high altitude, 2,3 DPG increases due to more glycolysis. So the only correct answer here is fall in arterial CO2, right? Fall in arterial CO2. Moving to 21. So an important non-respiratory function of the lung. Read up the non-respiratory function of the lung from the books. They can be asking you this other short note. So important non-respiratory function of the lung. Remember, we have the enzyme ACE, which is present in the pulmonary endothelial capillaries. So next time somebody asks you where is the enzyme ACE, please do not say lungs and tell them it is where in lungs. They will ask pulmonary endothelial capillaries. ACE enzyme acts and converts your angiotensin 1 to angiotensin 2. Angiotensin 2 stimulates the layer zona glomerulosa and causes the release of aldosterone. And I think you should be able to tell me the answer now. Aldosterone increases the sodium reabsorption, right, in the collecting duct. P cells, that we'll be learning later on in renal principal cells. So the best answer here is none other than sodium valence. P cells stand for principal cells. Moving to 22 now. So when the respiratory drive for increased pulmonary ventilation becomes greater than normal, a special set of neurons that are inactive during normal breathing become active, contributing to respiratory drive. So where are these neurons located? Remember, I was just telling you earlier that we have a DRG and VRG. So remember, DRG is only required for normal inspiration and expiration. But we have another center known as ventral respiratory group of neurons, which contain both I and E neurons. But DRG contains only I neurons, right? So it is required for normal inspiration, expiration. VRG, which contains both I and E neurons, these stimulate your accessory muscles of inspiration and expiration. Accessory means the muscles which are not required normally. Remember, when will they be required? When you need accessory means when you need more ventilation. One answer which should come to your mind immediately, such as in exercise, right? So not required normally. The answer is none other than VRG. Which are the accessory muscles of inspiration? Sternocleidomastoid, scalenus, serratus anterior, and a little roll of pectoralis minor and major. Accessory muscles of expiration, entire abdominal group, external oblique, transverse abdominis, internal oblique, rectus abdominis, and internal intercostals, right? Moving on to question number 23. Compared with the arterial red blood cells, which of the following will be or best describes the venous RBCs? Very, very interesting question. We are asking you venous. See, what happens here is, suppose this is a representation of the RBC. This is, let's say, your RBC. This outside is my plasma. Inside the RBC, this reaction occurs. CO2 combines with the water to form H2CO3, which splits into H plus and HCO3 minus. Interestingly, remember, this reaction is able to occur because RBCs are rich in the enzyme known as carbonic anhydrase. Carbonic anhydrase. So they are rich in carbonic anhydrase. Now what happens is, once I have produced HCO3, remember bicarbonate chapter 1 is an osmotically active particle. But this doesn't remain here. It goes out, and in return another negatively charged ion comes in. This another negatively charged ion which comes in is chloride. This is famously called by the term anion exchange, mutual exchange of anions based on their concentration gradient. Bicarbonate is more inside, it is going outside. Chloride is more in plasma, it is coming in. This name of the anion exchanger is anion exchanger 1, or popularly in the RBC is known by the term band protein 3 in the RBCs, right? But what happens now is once the chloride moves in, this is also known by the term chloride shift. Chloride shift. Chloride shift was discovered by a scientist on whose name we call it also by the term Hamburger phenomena. Now chloride is osmotically active. One osmotically active particle was generated inside. It went out, but another one came in. So as the chloride comes in, remember who will start following the chloride from outside? Who follows the osmotically active particle? None other than water. As the water starts coming in, what will happen if the water starts to come in? Think about it. Now the water starts to come in. What will happen to your RBC volume? The RBC volume slightly increases. That means the venous RBCs are swollen than the arterial RBCs. So this is commonly called as, this is the reason that volume of the RBCs in the venous blood is 1 to 3% more than arterial blood, right? So very interesting question and must know. So the answer is none other than, let's have a look at the options now. Increased intracellular concentration, increased cell volume, right? Now I'm taking you to question number 24. Hering-Breuer reflex is an increase in. Remember, Hering-Breuer reflex is that when you do prolonged inflation or with increased inflation of the lungs, when you do prolonged inflation with increased inflation of the lungs, this causes increased stimulation of the vagal afferent fibers. Once the vagal afferent fibers are stimulated, you already know what they will do to your depth of inspiration. I think you can recap for me. I've just drawn the figure earlier in the transaction one. So this causes decrease in depth of inspiration and increase in duration of expiration. This is popularly called as Hering-Breuer inflation reflex, right? So when we are asking here, although I have not written, but actually they mean inflation. If they want to ask Hering-Breuer deflation, they will write deflation, right? So we could have written inflation here also for you. So let's look at the options. Duration of inspiration will decrease, depth of inspiration decreases, but duration of expiration increases, right? That's the best answer. Moving to 25. Hypoxemia produces hyperventilation by a direct effect on. That means once your arterial O2 decreases, right, in the blood, that is known as hypoxia. So this hypoxemia will stimulate the ventilation by which receptors? Remember, J receptors are stimulated by irritant chemicals. That is not the answer. Lung stretch receptors will not be stimulated. That sense the stretching of the lung, and the vagal afferent fibers will be stimulated. Now I am left with medullary chemoreceptors. Remember, that is not the answer because hypoxia does not do anything to your central chemoreceptors. The only correct answer is carotid and aortic body, which, mind you, we have just studied, are known by the term peripheral chemoreceptors. And remember, for peripheral chemoreceptor, the primary stimulus is, or the main stimulus is always hypoxia, decrease in O2, right? So the only correct answer is carotid aortic body chemoreceptors, right? So almost we have taken a good time to discuss all these topics. So I hope that your concept should be clear and you have seen the videos, right? So I will again say that apna time apun khud laega. You have to work hard to bring your own time. Just keep on studying, and wishing you the best of luck for your upcoming exams. So take care. God bless you all.